Hello everyone, today we'll be talking about right bundle branch block and its ECG changes. Coming to the basic electrophysiology, in a normal cardiac conduction, impulses usually travels down the left and right bundles with the septum activated from the left to right. So the normal conduction, what happens is from the SA node, it goes into the atrioventricular node, and from the atrioventricular node, it goes into the septum, and from septum, the depolarization usually occurs from the left side to the right side. So this is the left ventricle, this is the right ventricle. From the left side to the right side, normal depolarization occurs, and this depolarization of the septum leads us to a QF. So that's what happens initially normal. In case of a right bundle branch block, so what happens in the case of a right bundle branch block is that this conduction is to the from the AV node, his bundle forms, and then there is right and left bundle is there. So the left bundle branch is normal. The left right bundle branch is blocked in the right bundle branch block. So left side conduction is normal. Initially, there will be slow activation and depolarization of this left side of the ventricle, followed by, because of there is the right bundle branch block is there will be slow progression, slow passing of this depolarization wave from the left side to the right side. So right side depolarization will occur a little later when compared to the left front, and that's why that forms a separate QRS. So left ventricular activation via the left bundle branch occurs early, and septal depolarization, that is, you can see here by a black arrow, the left depolarization occurs earlier, and then you can see the right septal depolarization, that is yellow QRS. There is yellow arrow you can see here, and then there is a right ventricular depolarization. Thus, the resultant what happens is there will be delayed R wave in the lead V1 and V3, V1 to V3, which represents the right side lead. So V1, V3 comes here, right side lead more common. So you can see here. The pattern will be this pattern. So initially, a small R will occur. Basically, this one is basically because of the left ventricular depolarization, and this second R wave is basically because of the right ventricular activation. So this gives rise to what is called as M pattern in the right sided leads, called as V1, V2, V3, and the W pattern, reverse pattern, will be seen in the V6. The ECG changes will be QRS duration will be more than 120 milliseconds because the right bundle branch block is there. So right ventricular is depolarizing little later. So QRS, the duration of the QRS will increase. RSR pattern in V1 to V3 is called M-shaped QRS. And slightly opposite changes in the opposite leads, that is V5, V6, and there will be slurred S wave. You can see here there is a slurring of this S wave in the V5, V6 lead. Okay, so this you can see here. So this is RBBB. Generally, that is what is called as reciprocal changes, because when there is depolarization, if there are some changes, opposite changes may occur in the repolarization phase also. So there will be discordant changes, that is STT wave inversions will be seen along with that. So in prognosis of right bundle branch block in patients without significant heart disease, right bundle branch block does not have any additional risk. The patient, if it is can be a normal variant also. But if a patient is known to have some cardiovascular disease, or patient is known to have MI or heart failure, presence of right bundle branch block generally denotes that there are high chances of higher mortality. Also increases the risk of mortality as well. In healthy patient, it is quite normal, whereas in cardiovascular disease patient, if this type of pattern is there, it leads to it considered as a poor prognosis or higher risk of mortality. Coming to left bundle branch block. So in left bundle branch block, what happens is that in left bundle branch block, so from SA node, the activation of the action potential occurs from the SA node in the right atrium to AV node, and from AV node goes into the his bundle, and then generally the septum get depolarized from the left to right side normally. Now in left bundle branch block, what happens is that the left branch is blocked, but the right bundle branch is normal. So there will be initial activation of the right ventricle. So right ventricular activation is there, then there is followed by a left ventricular activation. So what will you see is because left ventricle is activating little later, QRS duration will be more than 120 millisecond. We will see a dominant S wave in the V1. That is, reverse changes will be seen when compared to RBBB. You can see in left-sided leads, that is in the V5, V6, you can see this LBBB. The second wave is because of the left ventricular activation. The starting one is because of the right ventricular activation. Reverse changes in this one. And also there will be associated appropriate discordance will be there. The left axis deviation will be there. The proper discordance means that abnormal depolarization should be followed by abnormal repolarization as well, which appears discordant to the preceding QRS complex. So based on the QRS complex, it will be reverse changes will be there. So if you have this one there and reverse, you can see the positive QRS here. Then you can see is STT inversions will be there in the proper discordance is not. So other changes which you can see is absence of Q waves in the lateral leads, and there will be prolonged R wave peak time of more than 60 milliseconds. So R wave peak time is the starting of the R wave to the peak of R time, that will be slightly delayed because this is basically occurring because this is a bundle branch block and there is delayed activation of the right and left. The right ventricle gets depolarized earlier and the left ventricle gets depolarized little later. You will see this changes in this. So also, if there is a negative QRS, you may suspect this as an ST elevation here, because you can see here ST segment is the isoelectric line is here. As you can see, elevation is there. So this elevation is commonly present in LBBB, but this elevation is significant only if this elevation is more than 25% of this total height. There is separate criteria for that. It's called Garbosa criteria, which I'll be telling you in my next video. You can see my channel for the Garbosa criteria as well. When to consider this ST elevation as significant, we should know. Otherwise, it is a normal variant in case of LB. So we'll talk about Garbosa criteria. Garbosa criteria is basically used in left bundle branch block. In patients with left bundle branch block, what happens is that in left bundle branch block, you have uh, you will see a M pattern in the V5, V6 and a W pattern in the V1 and V2. Wherever there are negative QRS is there, there will be discordant changes will occur. Discordant changes will be seen in the ST and T waves. So depolarization and repolarization, there will be discordant changes will be seen. So you may see a ST elevation here. This ST elevation is not significant. It is considered significant for which there is a criteria is given is called as Garbosa criteria. Garbosa criteria, it means concordant ST elevation of more than 1 mm. Suppose there is this is a what does concordant distillation means, that wherever there is a positive QRS is there, if that wave, normally what we have said in LBVP is that if there is positive QRS, there should be ST depression and T inversion should be there. But if you see ST elevation, ST segment elevation, if you see rather than ST depression in the concordant lead, and if that is more than 1 millimeter, it is called as a positive sign, and this signifies that it has a score 5. So that means that if this feature is there, it is suggestive of myocardial infarction. Second is concordant ST depression. If you see a concordant ST depression, that means if there is ST QRS is dominant here. You can see here the QRS is negative here, and so when it is negative, generally there should be ST elevation should be there. But if there is ST depression, if you see of more than 1 millimeter, if you see more than 1 millimeter ST depression in the concordant lead, then also it is considered to be significant. A score of 3 is given. What is excessively discordant ST elevation? So suppose normally, as you have said, that ST elevation will be there discordant. So if the QRS is negative, there will be ST elevation. If the QRS is positive, there will be ST depression. If excessively discordant ST elevation, that means that if it is more than 5 mm of elevation is there, if this ST elevation, that is J point is from baseline, if it is more than 5 millimeters, it is also correct, as called as a positive Garbosa criteria. This was the original criteria which was made, which was modified later on. Modification is only in one thing, where there is discordant ST elevation where it is given as more than 5 millimeters. It was changed that if ST elevation here, if it is more than 25% to the height of this QRS, then it is called as more than 25% of the depth of this S wave. Then it is considered as a positive sign. You can see here, this is a ECG where you can see here there is a AVL, you have LBB morphology and positive R wave is there. But you can see also see, so normally in this lead you must have a negative, there should be ST depression and T wave inversion. But you have seeing here is ST elevation and T upward, if you are seeing. So this is characteristic of what is called as a positive Barbosa criteria. Let's discuss about R wave peak time. R wave peak time is nothing but the time from the onset of earliest Q wave or R wave to the peak of the R wave. You can see here that is the onset of R wave or Q wave. So from the onset of the Q wave or R wave to the peak of R wave is called as the R wave peak time. So it is usually measured in the lateral leads, that is AVL, V5 and V6. It represents the time taken from the excitation to spread from the endocardium to the epicardial surface of the left ventricle, and it is said to be prolonged if it is more than 45 milliseconds. This is generally used sometimes to differentiate VT, ventricular tachycardia, from supraventricular tachycardia with aberrancy. In ventricular tachycardia, this RVF peak time will be prolonged, whereas in supraventricular tachycardia, this RVF peak time will be normal. What are the causes of prolonged RVF peak time is left anterior fascicular block. Whenever there is a delay, that means the ventricular contraction, if it is delay or there is discordance between the right ventricle and left ventricle, this prolonged that is RVF peak time can be seen. Because so there's a left anterior fascicular block, left bundle branch block, right bundle branch block, and left ventricular hypertrophy. Let's talk about left anterior fascicular block. Left anterior fascicular block. So before going to the left anterior fascicular block, we should know the basic anatomy which is very important here. So the normal electrical system consists of a SA node, which is the pacemaker. So SA node goes and depolarizes the AV node. From the AV node, this comes as a bundle of his, and this bundle of his then it divides into what is called as the anterior anterior fascicle, and posterior fascicle. You can see here that anterior fascicles generally goes from here towards the left ventricle. The posterior fascicle goes directly downwards to the apex. Okay, this is very important to be known because based on this only we get the ECG features. So you should be aware that the left ventricle fascicle goes directly towards the ventricle on this side, the free wall of the ventricle, whereas the left posterior fascicle generally goes towards the apex. So now in left anterior fascicular block, what happens is that, so in left anterior fascicular block, when if these fibers are blocked, the depolarization wave will initially go into the left posterior fascicle block. So normally there will be left posterior fascicle block will get activation. So activation will occur here initially, and so all the vectors are going in the direction of lead 2-3 AVF. The initial activation will occur at the lead 2-3 AVF. So there will produce a small R wave because the voltage generated is not sufficient. There will be a small R wave will be there in the lead 2-3 AVF. And later on, what happens whenever this anti-rotation get activated, all these things will go and then depolarize this major ventricle here. This major ventricle direction depolarization from here to here. That is in the direction of lead 1, V5 and V6. So lead 1, V5, V6 will produce a dominant R wave. Dominant R wave in lead 1, V5, V6, and a small R wave in lead 2, 3 AVF is a feature of what is called as left anterior fascicular block. We'll see a left axis deviation. We'll see a small Q and a R complexes in the lead 1 AVL. As I said here, 1 in AVL, you will see a dominant R wave and a small R, and S complex will be seen, that is 2-3 AVF, you will have a dominant S wave. And as prolonged R wave peak time may occur. Prolonged R wave peak time is occurring because R wave peak time is nothing but is the starting of the QRS to the peak of that. This RV peak time will be more than 45 milliseconds because there is a delay in ventricular depolarization because of a left anterior fascicular block. So you can see here in the lead 1 and AVL, I said because there is a dominant direction is in this direction, major ventricular depolarization is in this direction. You will see 1 and AVL positive R wave. And in the inferior leads, you will see a small R wave and the deep S wave. S wave can be seen. This is suggestive of a left anterior fascicular block. Left posterior fascicular block. Left posterior fascicular block is explained by a concept for which we should know the electrical activity of the heart. So first it consists of a SA node from which the depolarization goes into the AV node, then it goes into the bundle of His. And from bundle of His, two fascicles forms. One is called as anterior fascicle and the posterior fascicle. The anterior fascicle generally the depolarization goes towards the free wall of the left ventricle, whereas the posterior fascicle goes downwards here. Now suppose you have a left posterior fascicle block. Suppose the left posterior fascicle is blocked. What will happen is that the depolarization will now initially go to the left ventricle free wall. From free wall will get activated initially, and this activation will, the small part of this one will get activated. Thus, this will produce a small R wave. So, small depolarization here will lead to a small R wave generation over in this direction in the lead 1 and AVL. And then from here, the depolarization will go into the major ventricle part. Major ventricle, the direction of this major ventricle is downwards and will produce a major voltage, and that's why lead 2-3 AVF will have a dominant R wave. Dominant R wave will lead to 3 AVF and a small R wave will lead 1. The feature of, so small R in lead 1 and AVL Dominant R wave will lead 2, 3 and AVF, and then right axis deviation, suggestive of what is called as left posterior fascicular block. So you can see here in the lead 2, 3 AVF there is positive R wave, and there is only small R wave in the lead 1 and ABL you can see here, and this is suggestive of left posterior fascicular block. Left posterior fascicular block is much less common than left anterior fascicular block, as the broad bundle of fibers that comprises the left posterior fascicle are relatively resistant to damage when compared with the slim single tract that makes up the left anterior fascicle. It is extremely rare to see a left posterior fascicular block in isolation. It usually occurs in combination with right bundle branch block. And do not be tempted to diagnose left posterior fascicular block until you have ruled out the other causes. If you see a left posterior fascicular block, you should always try to look for other causes of right axis deviation. And after ruling out this right axis deviation, other causes only, if you don't find any of this cause, then only you should label the ECG as left posterior fascicular block. Coming to bifascicular block. As the name suggests itself, bifascicular block means there will be two blocks will be there. So the right bundle branch is blocked, and along with right bundle branch block, if either left anterior block, left anterior fascicle, or left posterior block, either of this is any of one is blocked, then it is called as bifascicular block. RBBB with left anterior fascicular block or RBBB with left posterior fascicular block will manifest as a with. So if there is left anterior fascicular block, there will be left axis deviation. If there is right axis deviation, if there is left posterior fascicular block, there will be right axis deviation. You can see here in this ECG, this RBBB pattern. You can see that is M pattern in the V1 and V2. The discordant STT changes here. You can see here, and then you have left anterior fascicular block where there will be positive R wave in the lead 1 and ABL, and a small R wave in the lead 2 and 3 ABFs inferior. So this is the left anterior fascicular block along with RBBB, consist of bifascicular block. This is, you can see here, this is a RBBB pattern again in the V1, V2, V3, and then you can see a positive R wave in the lead 2, 3 AVF, and a positive S wave in the 1 end AVL here. If you see a dominant S wave in 1 AVL and a dominant R wave in the 2, 3 AVF, this is the left posterior fascicular block along with RBBB, suggestive of a bifascicular block. Trifascicular block. Trifascicular block is refers to, as the name says, there that it means there is a blockage of all the three fascicles. So what are the three fascicles? Is one is right bundle branch, left anterior left anterior fascicular block fascicle, left posterior fascicle. If all three are blocked or all there is delay in conduction in all three, then it is called as true trifascicular block. In actually true trifascicular block, there will be, because of the blockage of all these things, there will be third degree AV block. So that means there is complete block will be there, because no conduction can go through this. So there is complete blockage there. So atrium will beat independently now, and ventricle will beat independently now, and there will be associated AV dissociation, because there is no conduction is left to go from the AV node to the ventricle here. You may see two ECG patterns. Then is the first one is RBBB with LAFB, that is left anterior fascicular block with a third degree AV block, or you can see third degree AV block with RBBB plus LPFB, left posterior fascicular block. So associated AV block is important here. So trifascicular block. You can see here, this case you have RBBB is here. You can see dominant one and AV R wave in the one and ABL, that is left anterior hemi block. There is AV nodal block as well, and as you can see there is multiple P waves, and there is no relation between this P and Q waves. So there is third degree heart block here. So it is called as trifascicular block. Coming to masculating bundle branch block, this is called as MBBB. These consist of a mixed pattern of RBBB and LBBB. Patient will have both features of RBBB and LBBB. So in the precordial leads, that is in the chest leads, patient will have RBBB, whereas in the limb leads, patient will have LBBB. It is indicative of severe and diffuse conductive system disease and carries a very grave prognosis. Compared with typical bifascicular block, these have more extensive fibrosis and degeneration. Patient have higher risk to progress to complete AV block in this group. So ECG features are RBBB pattern in the chest leads. You can see here precordial leads, there is RBBB pattern. Whereas in the limb leads, you can see here one ABL, you have the M pattern here. And this is suggestive of LBBB in the limb leads and the RBBB in the chest leads, suggestive of masculating bundle branch block.